Good day everyone, Doc Mika here, and for this lecture video, we will be discussing fluid therapy in large animals. Patients undergoing surgery might need rehydration and electrolyte therapy, especially in cases of surgery in the gastrointestinal tract. Now, the difference between small and large animals, I believe you could imagine how difficult the approach is for fluid therapy, and especially with the three types of fluid therapy that we have learned in surgery 1. But do not differentiate these two groups of animal species just because they have different body weight, different sizes of the body, different species, or different water requirements. All right, remember the reason why we give fluid therapy. All right, there's a lot of reasons. I'm not gonna explain each one anymore because we have repeated that time and time again. All right, but think of these two animals by the difference between the number of cells each of them has. All right, so how much would a dog would lose for it to show signs of dehydration, and how much would a horse need to lose for it to show signs of dehydration, right? Dun pa lang, magkaiba na. And of course, the number of cells which could undergo the compensatory mechanism when fluid loss happens are two different things. So keep an open mind if the techniques or the protocols that we usually apply in small animals would change or would not be applicable in large animal approach pagdating sa fluid therapy. All right. So this lecture video will be focusing on the surgical approach of fluid therapy. The therapeutic approach in fluid therapy, I believe, will be discussed and more emphasized in your medicine subjects, which are species specific, and they will teach you on how to utilize fluid therapy as a therapeutic tool for specific diseases. So I believe they're more knowledgeable about that. I'm not going to touch on it. And I would hope that you keep an open mind as to how different it is. If you consult with one vet, if you read 10 books, if you read 50 journals, which I tried to do, and it was messy, you will see a lot of numbers shown to you, a lot of different dosages for different fluids, a lot of different rates, right? So I believe every author is basing it on their experience, and that's why I always repeat it every time that depende sa makakausap nyo, yun yung nag-work sa kanila. So that's how they do their diagnosis and treatment. But for this lecture, we will be going at it, the fluid therapy used in large animals in this manner. We're going to discuss the choice of solutions. So we are going to review the commonly used fluids, intravenous fluids at that, the maintenance rates. I hope you still remember the maintenance rates for dogs and cats. All right. We are going to review the three approaches for fluid therapy. Ano ba yung tatlong application or direct application ng fluid therapy pagdating sa mga hayop? We are going to learn the estimation of fluid deficit, learn the routes of administration and the manner of how to do them, and patient monitoring. At the end of this lecture, I also included on how to incorporate drugs, especially analgesics, into your fluids as a continuous rate infusion, wherein you mix the drug into the bag of the fluid para tuloy-tuloy na merong pumapasok sa katawan ng hayop na drug, which is very good for pain management. And also I included a slide for glucose supplementation, which is very much a benefit for young foals and calves and even kids and lambs. All right, let's go to choice of intravenous fluids. I hope you still remember the different fluids, all right? But here's the thing. There are a lot of types of fluid, right? You have the crystalloids and the colloids. In the crystalloids, as a review, all right? I hope you still remember it. There are three based on the tonicity or the osmolarity of the solute and the solvent inside that bag, right? You have the hypotonics, the hypertonics, and the isotonics, which would have a similar osmolarity with the blood plasma, all right? So I included in this slide the breakdown of each electrolyte within a certain fluid. Now, I would like you to focus on the osmolality. Osmolality, when we discuss biological fluids, right? When we discuss biological fluids, it is interchangeable with osmolarity because it's just a difference in denominator. Osmolarity would be over kilogram. Osmolality would be over liter. So in chemistry, of course, they're different. But when we talk about biological fluids, which what we are talking about now, the two are interchangeable. So each fluid, each type of fluid, doesn't matter as to the contents of it, would have a level of osmolality. Why does this matter? All right? Yung mga label ng intravenous fluids that you see in a clinic or what you use, in your surgical laboratory, why does it matter? Do you have to memorize this? Not really. But what you have to remember or to understand is how it relates to the normal body's physiologic osmolality, right? Especially in large animals. That's around 280 to 310 milliosmoles per liter. Why is that important? All right, remember, your body is composed of cells. Within those cells, there are ions and such. You have cations and anions. And there must be a balance of these electrolytes. That's why I always repeat, electrolyte imbalance. When it happens, there's something wrong. Your body creates a way for it to balance itself. All right, that is what you call the process of homeostasis. Remember, all right? So you wouldn't want to put something inside the body which is so far, right? Which is so far from the normal physiologic osmolality. Because why? What will happen? Okay? Pag masyado kang nagbigay ng mataas na sodium sa katawan, right? And honestly, you're not just putting sodium. Look at the normal saline, right? 0.9% NaCl. When you look at the content of sodium, that's 154 millimole per liter. Chloride will be 154 as well, for a total of 308. That is how osmolality is computed. The amount of cations and anions in a fluid. All right? 308. Not bad. But you're in the upper border. All right? You're in the upper border. It's very hard to work downwards from that. Remember, you already have sodium inside your body. You're putting, again, a lot of sodium and chloride inside the body. We'll be focusing on sodium chloride in the next slide, but I'm just showing you the difference between saline and the balanced electrolyte solutions, as we call them. Lactated ringers, normosol. Another name for normosol is plasmolite. All right? Not very commonly seen in the Philippines. I am not sure why. I've seen some clinics carry this. Maybe it's what do you call this? Resources thing. Saline is cheap. That's why it's commonly used. It's very cheap. And you could actually make it easily. It's 0.9% sodium chloride. Mix some water with table salt. That's it. At a right concentration. Right? But look at how close or within the range is of the normal physiologic osmolality is the lactated ringers, or what we call Hartmann's as well, and the normal-sol. Alright? Mas komportableng laruin yung mga numbers within this within the balanced electrolyte solutions as compared to saline. That's why when your first bag of choice, alright, when you decide your first bag in the practical setting, okay, when you're in that judgment mode, ano ang gagamitin mong fluid, alright, you usually make that decision with limited clinical pathological data. Okay? Hindi mo pa alam kung anong BUN at CREA niyan. You do not know if it has, has a kidney insufficiency or hepatic insufficiency. You don't know how much of an electrolyte it has or how much it doesn't have. Right? So, ang laging question pagdating sa clinic, even in large animals, because you have to when you're a farm vet and you are called in to consult, your car, whatever it is, a truck, an SUV, whatever, you have to be well packed and ready for anything. So, kahit hindi sabihin sa'yo na magdala ka ng swero, dapat may dala ka. Hindi sinabi sa'yo na magko-collect ka ng ihi, kailangan may dala ka. Alright? That's how prepared and how anticipatory the approach is pagdating sa farm. Alright? Because if you are a consultant and you just called in, hindi ka nakastay in sa farm, like some of the farm vets that I know, you have to be ready for anything. Hindi pwedeng, wala akong dalang ganito. Babalik muna ako sa clinic or babalik muna ako sa bahay. Bibili muna tayo ng ganito bago ko magagamot yung baka. Right? It doesn't work like that. Right? As compared to a clinic wherein you have everything there, farm veterinarians, you have everything in your car. Right? Unless you are stayed in, you have to make sure that your farm is complete. Right? So, ang laging tanong, ano ba yung fluid na kumbaga all around? Diba? Ano ba yung lagi nating, kumbaga the best choice as a first bag while you were waiting for more data for you to make a more sound judgment pagdating sa fluids? It would be your balanced electrolyte solutions, lactated or normal salt. I wouldn't usually go for saline. That's the last. Because it's very, the risk for you to induce hypernatremia to your patient is very high, right? That is why in your clinic path, you have to know the normal concentration of the electrolytes in the body, right? You know, and my tip for you, because when you see the normal reference intervals for these blood parameters, you usually see intervals 140 to 148, 2 to 3.5 and such. 3 to 5 for potassium or something like that. Choose the middle one, right? Choose the middle one. My marker for potassium is 4. For sodium is 140. It's always like that. Make it easy for you. Lalo na pag nasa clinic ka na, you cannot keep on looking at the book. Mawawala na rin yun sa sistema mo later on eh. Because you have to work efficiently and you have to work accurately when you do your thing. Especially in the farm. So, hindi ka pwede magbubuklat ka or check ka ng phone. Choose one number. Okay? In the practical setting, ha? Na practical setting. Na alam mo na tipong, pag malapit-lapit na dun yung number na nakita mo na result ng hayop, then you know if it's too low or if it's too high or if it's in the middle. Alright? So you don't have to memorize this. My tip for you is just choose a number that you will stick with for you to be reminded of the normal range. Alright? Kasi napakahirap namang alalahanin ng lahat ng range na yun when it's just random numbers. Diba? Alright, let's go into the different fluids. Saline solution, very inexpensive, very much commercially available, and when you're in a farm, you could actually make this, right? Cation would be 154 equivalent per liter, equal with chloride, because it's sodium chloride. pH is a little bit acidic at 5.5, and I'll show you this. Okay, again, this is my normal thing in my head. The normal sodium concentration in the body is around 140. right? So yung yung 154 na idadagdag mo, that's okay, right? You're in excess of 14, but that's easily compensated by the body to for it to be excreted kapag sobra. Right? There's a lot of places where your what do you call this? A sodium could be placed in for it to be excreted. Saliva for one, urine for also, sweat and such. Chloride is different though. Right? Look at it. The normal chloride in the body is only 100, and you're putting an excess of 54. Ngayon, saan dadalhin niya ng katawan mo? Hindi naman yan as easily excreted in the same mechanism as sodium. Chloride is different. Chloride, yung burden ng 54 na extra na milli-equivalent per liter will be put on the kidney for it to be excreted. Alright? So this is why some veterinarians, I'll say some, alright? Because again, it's cheap, it's easy, it works. You don't see the chloride go up. When you see chloride go up, sometimes it's an error with your what do you call this, blood machines or such, or hindi siya masyadong focus on. But hyperchloremia is a condition wherein you did clean path already, but you don't see its result once your kidney is hit. And you know for a fact that when your kidney is hit, you're counting months and years only, right? So this is why I always like researching more and more about things, because when I graduated, I didn't know shit. When I was working in the clinic, I didn't know shit. I was doing saline. I was using saline over and over again. No one taught me otherwise. But then when you actually read on stuff, and then you just form questions in your brain, you're like, oh shit, yeah, I might have induced some patients to undergo renal insufficiency just because I've been using 0.9 saline, thinking that it's the safest option. Apparently, when you just look into the ingredients, it's not. Diba? So again, when you talk to different veterinarians, they might have different opinions. But I'll stick with what I see here, and it's simple math, right? Still, there's a lot of applications of saline, right? When there's prolonged diarrhea, you would expect hyponatremia. God, I forgot the term for that. There are some cases wherein a patient suffers from hypochloremic metabolic alkalosis. Vomiting for one. Why? Would vomiting lead to low chloride in the system? You know this. Why? Because when you vomit, you excrete hydrochloric acid from the stomach, right? That's good. Yeah, that's one reason. When it happens severely and it happens so frequently and it's not resolved, the body actually undergoes hypochloremia, and they could benefit from infusion of saline, right? And another condition that could lead to low chloride would be torsion in the gastrointestinal system of a ruminant. For example, abomasal torsion. Abomasum is the true stomach, remember? So that is where HCl is produced. Right? Remember, four compartmentalized stomach. Okay? So when that HCl cannot be, is trapped there kapag nag-twist. So the body just produces excessive HCl inside, but it's not going where it needs to be. The gastrointestinal motility is basically stopped. So the chloride concentration in the blood actually goes down. Okay, a ruptured bladder was found to show a low sodium, low sodium, and of course the classic when you want to when you want to maintain the IV catheter integrity to prevent clots from developing around or within the catheter, you make sure you flush the catheter maybe around every 4 hours if it's not connected to an IV line with a continuous infusion. So, naglagay lang kayo ng IV cath for IV access. For example, you're expecting, what do you call this? You're giving it IV drugs, but it doesn't need fluids anymore. So, you're just giving IV medications. So, you have to make sure that you flush that. And you use saline, and we usually mix saline with a little bit of heparin para walang clot na mag-form, or to prevent any clot from forming on a catheter. Alright. Lactated ringer solution, Hartmann's, in the discussion or in the lecture by Berenger Ingelheim with Dr. Gerardo Poli, this is what his answer is when he was asked, what is the fluid that you always need in your clinic and that could be applied most in a lot of cases? And of course, he's talking about in a small animal perspective. But when I asked my professor friend, equine practitioner, he agrees that it's lactated ringer solution as well. Number one, because normal sol and plasmolite are not in the Philippines, but he says that this is the what he has all the time in his car when he does consultations, right? So as to the contents, cations would be sodium, potassium, and calcium. That's one thing that is pointed out when you study fluids. Lactated ringer solution has calcium in it. The anions would be chloride. Lactate would be included as an anion because it's the buffer for it. In totality, the osmolarity of this fluid is 274. So within that range, actually very good. And with a pH of 6.5, it is actually referred to as an alkalinizing fluid along with normal sol and plasmolite. Now, a lot of conditions actually cause your body to go into an acidotic condition or an acidotic status. I don't want to review you in the metabolic acidosis anymore because I hated that part. So, infusing animals in an acidotic state with alkalinizing fluids actually works. However, one thing that is that was found to be a disadvantage with LRS is that the calcium content in it causes some drugs to precipitate. So if you're working in a clinic, all right, I would be very interested to hear from you about your observations, all right? Na kapag nagbibigay kayo ng IV drug to a patient that is connected to a line with LRS, watch your drugs as you inject it, especially those that you have to infuse slow IV, right? Because this I've experienced this as well. I was guilty of this as well, and no one corrected me. Na kapag nag-infuse ako ng, I think one is furosemide, vitamin C, some brands of vitamin C, you see na nagiging chalky yung line papasok dun sa vein ng animal. It's because your drug actually reacted with the calcium content of the LRS, and that caused the drug to precipitate. So that's one disadvantage. But then again, still, it is the fluid of choice. All right. Now, one question: lactate. I'm not gonna ask why you're not gonna give it to those with liver problems. You know that already, right? But what is it for? Right? What is lactate for? You also see this in other fluids. You have acetate, gluconate, the last word in some drugs. What are those? Remember, fluids are made with a buffer, right? Again, you want to maintain a certain pH. That's why you have buffers, right? So the basic buffer that we have, chem-wise, is bicarb, right? Bicarb is the ultimate buffer. However, when you put bicarb in a fluid, like this, in a bag, and then you sterilize it, bicarb dissociates really fast. And it dissociates into hydrogen ions and carbon dioxide. So basically, your buffer is gone. Alright? So pH changes in your fluid is easily happening because of the interaction between your cations and anions. So that role as a buffer is taken up by lactate for this fluid. And these buffers, lactate, acetate, gluconate, are stable when they are heated or when they are exposed in sterilization, we call this mechanisms, right? And all three are metabolized by the liver, and that is where they are converted to bicarb. So that is why you also require a reasonable liver function when you use lactated fluids, okay? Which you already know that, right? So when you use it, this is the excellent first bag choice. You could use it for temporary blood loss because it's almost similar to plasma. It is your isotonic crystalloid of choice when you give resuscitation fluids. Since it is alkalinizing, it is indicated for metabolic acidosis and for daily fluid maintenance. Now, I hope you would do this when you get a clinic or when you're actually doing it now. Kudos. That you have to monitor the electrolytes of any patient that are receiving intravenous fluid therapy. You don't have to do this every day. Ideally, for those long-term na naka-IV, parvo, stemper, kidney, especially the kidney patients, they require electrolyte panel. For those na kidney problem, liver problem, hormonal and such, usually do it every day. Kung kaya ng client, of course. Strictly, it's every day. But for those na tipong naka-maintain lang sa IV, for maintenance, you usually check electrolytes every 3 days. So just for you to check if your intravenous fluid that you are giving to the patient is causing some imbalance itself. Because you don't want to give the patient something that its own body should correct. Right? Whatever you give to the patient, it should help the patient or it should alleviate some burden from the body. You should not give the body further things to metabolize or further things to be burdened about. Right? You got it, right? Okay. So, 5% dextrose in water and 50% dextrose in water, whatever, glucose in water. It's a basic source of energy. But since dextrose is easily metabolized by the cells, it's easily absorbed by the cells, used up by the cells, even if at that content, right? This is the best way. This is found to be the best way to give pure water into the body, all right? Especially if the patient is undergoing intracellular dehydration, right? Also, yes, it helps for those patients with hypoglycemia and for those with hyperkalemia. Assignment: how does it help? How does glucose infusion to hyperkalemic patients help the hyperkalemia? All right, assignment. I'm gonna include it here because if I include it in the first part of the lecture, you might skip on it. Thank you for the questions, and you'll know it if your question made sense if I reply really long. All right, if you saw how much effort I put into the answer I give you, you'll know that the question you asked is good, all right, or it made sense. Because sometimes I see some questions that are sent to me that are answered by the video itself, which means you just send me the question just for the sake of sending a question for your student participation. Then might as well don't. All right? Because if you ask me a question which is about something that I already taught you in the lecture, it doesn't make sense for me to answer you anymore. All right? I could just refer you back to the lecture video and watch it again. All right? So, one tip. I'm not discouraging you from sending me questions, but send me questions which are not answered by the lecture video. Because honestly, I left a lot of things untaught, okay, not included in the lecture video, just for the sake of you to ask me, right? And if you think those questions are not included in the exams, then what are you fooling yourselves, you know? All right. Glucose supplementation to balance electrolyte solutions could be taken out from this bag. And honestly, if this solution, even if unavailable as is, you could reconstitute it because the basic ingredient is dextrose. All right. What else do I need to say here? Nothing else. All right. Hypertonic saline, my favorite. It could come in different, what do you call this? Preparations, 7.2%, 7.5%, and look at that, a content of sodium chloride, right? Of course, equal osmolarity 8 times the normal in the plasma. All right, so it's quite acidic, and it has a high amount of sodium chloride in it. So when do you use it? When do we use HTS? I call it HTS. When? There's only a few indications for this, right? Shock, right? When patients are in shock, especially hypovolemic shock. Remember, you have 4 kinds of shock. I'm not going to go into that. I presume you know that already. Okay? So for those endotoxic, hemorrhagic shock, wherein you need a rapid expansion of the intravascular volume, right? You need to restore your normal circulating blood volume to maintain the functioning of your organs, to maintain a normal cardiac output and blood pressure. What you need is hypertonic saline. Okay? However, how does it work? How does hypertonic saline work? Basic osmotic effect, all right? Because there is a high amount of sodium in the blood vessel that will pull out the water from the intracellular and interstitial spaces so that you could expand the intravascular volume. All right. However, this has a short duration of effect, only an average of 30 minutes. Some horses in one study showed that it could work for 45 minutes. And this is the dose for that. 2 to 4 milliliters per kilo, maximum of 5 milliliters per kilo, given over 5 to 10 minutes. All right. So why did I put an asterisk on 4? A lot of literature that I read pointed to 4, right? To that standard 4 mil per kilo dose for hypertonic saline. Although some literature, I've read a lot. There's a lot of tabs open in my laptop right now. Said that it's 2 to 4 strictly, right? Because you can start low muna at 2, especially for foals and calves. But for example, if I ask you a problem, when I ask you to solve for something, let's stick with 4. All right. So it's one-time use, meaning after you give it, it doesn't work, right? It doesn't work, or it doesn't work as much. You do not give it again because it would lead instantly to hypernatremia. And with the mechanism of action of it pulling fluid out from the inside the cells and in the interstitial space, the use of hypertonic saline requires your animal to be very well hydrated. All right? So that question between dehydration and hypovolemia comes into play, which I'm sure you know the difference between dehydration and hypovolemia still. All right? So don't use hypertonic saline if you know na walang mahahatak yung hypertonic saline mo na fluid. You're just making more damage than the original problem you have to fix. All right. It was found that hypertonic saline, in addition to its circulatory effect, or its hemodynamic effect, if you want to be technical about it, has anti-inflammatory effects as well. So that's also one of the group discussions that I will be posting. What is the anti-inflammatory effect of hypertonic saline. Right? So Heta Starch or hydroxyethyl starch is a synthetic colloid. Okay, this is the only colloid that I'm going to discuss. I'm not gonna discuss blood this time. If it's very rare to see blood transfusion in small animals, it's much so in what do you call this? In large animals. So I'm gonna leave for med if they're gonna discuss it with you. All right, I'll stick with Heta Starch for now. All right. So synthetic colloid made from high molecular weight molecule, basically, what do you call this? From amylopectin. Oh, it's written there. Damn it. Which leads the infusion of this inside the intravascular space would lead to a colloidal osmotic effect. So basically, again, this will pull out the water through osmosis from the intracellular space and interstitial spaces, which leads to volume expansion inside the vessels. Right? The usual preparation of this is 6% solution with saline, or you might see it with LRS or plasma light. It depends to the manufacturer. It depends on the manufacturer. When do you use it? Okay, you want to increase the plasma colloid oncotic pressure, again for shock, to increase the blood volume, which would then increase the cardiac output and the blood pressure. Of course, in cases of hypoproteinemia, right, which actually happens in endotoxic shock, septic shock, peritonitis, and such. Coagulopathy, severe inflammatory conditions wherein you are deficient from proteins, and DIC. I know you know what that means. Disseminated intravascular coagulation. Right? Now, what's good with this one is that it works the same way as hypertonic saline, but it lasts longer, 24 to 36 hours. Right? So the dose for this is 4 ml per kg over 15 minutes. We will discuss later with resuscitation as to this way to combine the effects of Heta Starch and hypertonic saline para maliit lang yung amount ng fluid na ibibigay nyo sa pasyente, but it works. Right? Especially, again, the requirement for this is that your patient is not dehydrated. All right. Now, fluid therapy is given in 3 steps or in 3 ways. All right. I said these words earlier. What are the 3 approaches of fluid therapy, which also applies in large animals? This is how we divided the computations before. We have resuscitation. All right. First thing, this is administering fluids aggressively to a patient which is critically ill, which needs stabilization, circulatory stabilization. So this animal could be experiencing severe hypovolemia, shock, severe hypotension, which needs aggressive infusion of the fluids it has lost, or it has lost internally or externally, okay, for you to stabilize the patient. All right, so I hope you still remember how to recognize if a patient needs resuscitation or not. All right, because the approach for them are different. Remember how hard that is? How hard that is? All right. Replacement. Replacement is the approach of fluid therapy for those patients needing fluids to correct a fluid deficit, which happens with dehydration, and or electrolyte imbalances due to continuing losses. All right. These are pathological losses, meaning examples: vomiting, diarrhea, excessive urination. Right, edema. These are continuing losses. So the basic classic way of computing for the fluid deficit or gaano kadami fluid ang kailangan mong ibalik sa pasyente would be percent dehydration multiplied by the kilogram body weight of the animal. That will give you the amount of replacement volume in liters. And of course, let's not forget the maintenance approach, wherein you are simply giving the animal the amount of fluid that it needs to maintain its normal body function. Okay? Which that includes the physiologic losses from your normal urination, normal defecation, sweating, what else? Respiration and such. All right, so this is the amount of fluid the animal needs to stabilize its cardiovascular system. All right, to what do you call this? To keep its organs and tissues functioning normally. I think I just rephrased it. All right, let's start with maintenance. And I wouldn't apologize for it because it's hard work, but because it's a lot of computations that we are going to discuss. So I'm expecting a lot of questions, but it's quite easy. It's quite straightforward, especially if your foundation surgery one is still there. And surgery too, because you do this. But it's fairly easy. It's just a matter of we're talking about different animals with different maintenance rates. All right? Again, maintenance rates would be the normal fluid balance, which includes the water losses expected from that from a healthy animal. And so anything in excess from that would be included in the ongoing losses for replacement. All right? The maintenance rates between animals that we are talking about would be based on number one, species. Number two, physiologic status. Are they lactating or not? Are they dry? Are they pregnant? And based on age. Because as we have learned, young animals have a higher total body water content as compared to older. Not gonna repeat that anymore. Been repeating that all the time. So, ready? If you have to memorize this, yeah. But the thing is, your exams are online. You could actually FaceTime your friends while you're answering the exam. I know that. Don't post it because it's funny. It's time of the exam, and then you post FaceTime screenshots of you. It's just do better, man. Do better. All right. Non-lactating adult cows, 60 ml per kg per day. So I'm showing you this because this is your reference. All right. When I give you a problem, you go back to this. All right. So there's a pattern for this actually, and to make it easy. For example, in horses, if you need to make it into milk per kilogram per hour, it's just like that. 2.5 ml per kg per hour. So this is the amount of fluid your patient needs to function normally. Now, why would you need this? There are certain conditions wherein your patient is reluctant to eat or drink, and that is the primary source for fluids, right? When we feel dehydrated, when we need something, when we need fluids, we will get thirsty, so we will drink. All right. So your what do you call this? Your animals would show signs that it needs fluids. So maintenance rate would be what we apply during surgery because they are not eating, they're not drinking. For those animals which have to undergo general anesthesia, they are not eating, they're not drinking, and they have not eaten or drank anything for during the fasting period, which is usually 12 hours. So you have to give them the fluid that they are not getting right now because you're doing something to them, right? That's why it's maintenance. And it's also very common for some patients, even in small animals, that they just wouldn't eat or drink. That is why you give maintenance fluids. All right, I had to discuss maintenance rates first because I will apply that to resuscitation. Resuscitation is supposed to be the first one. All right, how do we recognize patients that need resuscitation? They are the patients showing signs of shock. How do we know they are in shock? They're in shock, doc. They're depressed, lethargic, they're almost dying if they're not yet dead. What else? You know this already. Maybe you're answering and I just can't hear it. I feel I'm getting crazy when I record these lecture videos. But I still have to make, what do you call this? I have to say these questions so that you actually still think whenever you listen to my recordings. So, what are the signs of shock? Okay, let's be specific. Hypovolemic shock, right? It's my fault. You see, depends on the stage. Yep, you have compensatory, you have the middle one, and then you have decompensatory, right? So patients in shock would have elevated heart rate, compensatory shock, elevated heart rate, decreased temperature, decreased blood pressure, increased respiratory rate. What else? Cold extremities because they want to focus the blood flow into the core organs, which is the heart and the brain. Right? So you know this, you know shock. Right? What do we do about it? We have a shock dose for crystalloids, isotonic crystalloids, which is 60 to 80 milliliters per kilogram, which corresponds to the circulating blood volume. This applies to horses, cows, and pigs, right? Okay. But most likely in our problems, we're just going to be discussing cows and horses because I rarely see fluid therapy in pigs, yet it happens, of course. So we're just gonna focus on horses and cows for this time. So 60 to 80 ml per kg, right? Now you don't give it as that, right? Shock dose. You don't give it as that. I think I skipped this in surgery 1. You give it in quarter doses. Okay? Let's play it at 20 ml per kilo. That's a quarter of your shock dose. And that's what you have to give ng dahan-dahan. Okay? Why? When you give 60 to 80 ml per kilo, agad in one sitting, imagine that's a 500 kilo horse. And you're giving 80 ml per kilo. How much are you giving it? Ilang bag ng fluid ang gagamitin mo? If you're using 80 ml per kilo times 500. You're gonna use 40 liters. Correct? Right? So, that is, and that is prone now, right? That is prone for causing fluid overload in your patients because you're basically replacing the entire blood volume when it could not have lost that much, right? So you give quarter doses and then you reassess. So when we apply that for this example, right? 500 kilo horse needing fluid resuscitation requires how much first of isotonic crystalloids? Use the quarter dose, 20 ml per kilo. 500 times 20 is, you don't need a calculator for that, but go ahead. 10 liters of isotonic crystalloids. Let's say it's lactated ringers, right? Still, when you think about it, damn, that's high. 10 bags of isotonic crystalloids. Whoo, right? But sometimes that's what you have to do, all right? Sometimes that's what your horse needs. That's why you give it, right? And actually, in some countries, I don't know, I wasn't able to ask my doctor friend that if they have this there. They have 5-liter IV bags. Diba ang standard ay 1 liter lang, yung laman ng isang bag. They have 5-liter bags here, which is cool. They're like a big bag. Parang yung 5 kilo lalagyan ng bigas pag binili mo. It's like that, just very cool. Right? So, Yun. So what's the big, what they call this? What's the big disadvantage of this? You're gonna use a lot of isotonic crystalloids, right? And you're going to be pumping a lot of fluids inside the animal's body, even if it's 500 kilos, right? That's 10 liters. So what's the option? That's where small volume resuscitation comes in. Okay? Is it new? A little bit. This article was 2017. I think. Gosh. I think it's 2017, which makes use instead of just crystalloids, all right? It makes use of hypertonic saline at 4 ml per kg, combined with Heta Starch at 5 to 10 ml per kg. That is the maximum for Heta Starch. 10 ml per kg, which is given over 20 minutes. All right? The shock dose there, it's given instantly. Paubusin mo yan agad. All right? No limit. You don't have to wait for like 10 minutes for it to be done. All right? In some IV lines, you could actually finish 28 liters per hour. 28 liters per hour pagdating sa horses. Depende sa kung gaano kataas mo siya ilalagay, because you're basically just using gravity for this. Okay? So, hypertonic saline plus Heta Starch given over 20 minutes. And even if your animal is well hydrated, you need to follow it with the maintenance crystalloids, which could be administered through the same IV after, or you could give it enterally through a orogastric nasogastric tube to maintain vascular volume. Because remember, your hypertonic saline and Heta Starch, okay, are the mechanism of it is that they will pull the water out of the cells. So meaning, yung cells mo naman ang walang fluid. So you have to follow the small volume resuscitation with maintenance crystalloids. Okay? You have to connect IV fluids into that animal for the next 24 hours para lang hindi siya ma-dehydrate. Okay? So if we use the same example, okay, 500 kilo horse needing fluid resuscitation, what is the option now if we're going to use hypertonic saline and Heta Starch? Right? Hypertonic saline muna. 500 times 4. How much? 2,000? That's ml. So that's 2 liters of hypertonic saline. Correct? Good. How about Heta Starch? Hydroxyethyl starch. Okay? If we use, let's do 5. Okay, let's do 5 first. If multiply 500, the body weight, times 5 ml per kg, how much Heta Starch do we need in liters? 500 times 5 is 2,500, which is in liters is 2.5 liters. Correct. Heta Starch. So you give that in combination. Actually, these two, hypertonic saline and Heta Starch, have synergistic effect, which increases the plasma osmolality and mas mabilis ma-mobilize yung intracellular water as compared if they are given separately. Okay? So that's why it's a really good option. So together, diba? That's 4.5 liters given over 20 minutes. As compared to your 10 liters of isotonic crystalloids, which might not even work, diba? You might need to add another bolus and another bolus for it to work. With hypertonic saline and Heta Starch, this is embraced right now by a lot of equine and ruminant practitioners because it's easily given. The products, ang mahal lang naman dito is yung Heta Starch, but when you buy it in bulk, it's cheaper. But it works really well. Okay? And especially in cases of foals, diba? If it's a foal na anak ng magandang breeder mare, diba? You need to keep it alive. Okay? And you have all these options. You go for the small volume resuscitation and then you monitor. Okay? Now, the monitoring thing. again, you need to follow this with maintenance crystalloids. What is the maintenance rate for horses? Okay? Horses ha, wag foals. Wag foals. Choose the horse para mas madali tayo. Oh yeah, you can't go back. You have the PDF file for this. Search for it. What is the maintenance rate for horses, adult horses? The milk per kg per hour. Look at the table, the slide before this slide. It's the second row from the bottom. 2.5 mil per kg per hour. So I need the mil per hour, actually the liter per hour. Okay, you multiply the maintenance rate with the body weight. So that's 500 kilograms multiplied by 2.5 mil per kg per hour. That is 1.25 liters per hour. So that's how much the horse must receive every hour for the next 24 hours after small volume resuscitation. So when I say assess, reassess the patient after you give a resuscitation bolus, especially for the crystalloids, what do you want to see? Everything that is wrong before should be correct now, right? For example, you have a downer calf, okay? You want it to be alert, you want it to be responsive, you don't want it to be down anymore, all right? One thing that is particular with calves is that they, yung suckling reflex nila has returned. They now have the, what do you call this, willingness to drink from the suckling bottles. So that is one good way of assessing these calves after resuscitation, which actually often happens after birth. Kapag matagal silang naipit dun sa pelvic brim, or the pelvic tunnel of the mom, usually their suckling reflex is very bad, so they cannot drink. So you have to feed them, we'll discuss this later with the enteral feeding. You have to discuss we have to give them the colostrum because they won't suckle. So that's very important for cows and foals. When you talk about horses, the specific fluid resuscitation goals are outlined in this table. So you want all those to be within those ranges. You want the extremities to be warm. You want the heart rate to go down, right? If it was too high, if it was too low, you want it to go high, right? The rectal temperature should now be within normal range. If it's not, it should be just subnormal. Wag yung masyadong mababa. So you know this. Okay. Now we discussed maintenance. We discussed resuscitation. Let's now go to replacement. How do we replace the fluid deficit? Again, this is computed based on the current level of dehydration and an estimation of any ongoing losses. Now, what's different in this case in large animals? All right, you want to be efficient. You want it to be done faster, and what do you call this? The bodies of the animals that you are taking care of can handle high volumes of fluid. That is why maintenance and replacement volumes are usually given together. Remember in in small animals, we usually give replacements una. You have to finish it within 6 to 12 hours, and then you shift the replacement. Here, it's easier. You just have to give them together. Okay, so it's much easier, right? Okay. So the total fluid volume that you have to give for dehydrated patients, all right, dehydrated patients would be the sum of the maintenance and replacement. This is given over a period of 12 to 24 hours. Now, again, the asterisk for 12 because this is preferred by a lot of authors upon my research. You might read in some books that those who are severely dehydrated, you need to replace it within 3 hours or 4 hours. It all depends on the condition. If you think it needs it fast, then give it faster. Again, there is no one rule in fluid therapy. It's all personalized, so it's up to you how you bend and how you adapt to different patients that you will face. Right? So maintenance, you know how to compute for it. You have the standard numbers that I gave you in that table. You just have to multiply it with the body weight. With the replacement, that's a combination of fluid deficit and the ongoing losses. Right? How do we compute for fluid deficit again? We multiply the body weight with the percent dehydration that we can infer from the clinical signs that is showed by the animal. For the problems for this course, I will be giving the percent dehydration. Okay? Because it's very overlapping. Mahirap. Even for me. I always just say 5% dehydrated because it's, that's the time that they show signs, and by the time they reach 15%, they're dead for dehydration. So easy. Ongoing losses, on the other hand, is again estimated based on the condition. The standard for dogs and cats applies here as well. It's 2 ml per kg per hour. Ongoing losses for vomiting and diarrheic patients. Right, so let's just play it at that, 2 ml per kg per hour. Remember, yung mga may asterisk akong nakalagay, yun yung pinaka-common na nakita kong rate sa libro /journal/handout. Okay? Because a lot of the handouts of the universities here in the US are shared online publicly, so you could actually see their standards. The problem there is you get to see too much rates and you don't know what's correct anymore. And then apparently it's based on their own experience and where they are, So, after you give a replacement a replacement volume, again, you need to reassess for improvement signs after every administration. Right? So, again, you do not just give the fluid thinking it's working already. Alright? You might think you might have the best estimate in the world as to the fluid deficit, depende sa mga nakita mong signs, but that could still be wrong pagdating dun sa specific animal. Because again, we can only estimate things, we cannot have a very accurate measurement of how much fluid it needs, how much fluid it is lacking. So, we use our best judgment pagdating dito. So, dehydration in horses, let's start with horses. How do we estimate fluid deficit? The following parameters are increased pag dehydrated ang pasyente. So, the heart rate is up, jugular refill time. Okay, when you occlude it not on the thoracic inlet, that's too muscled. Okay, it's in the middle of the neck of the horse, right? It's close to the thoracic inlet for cows. Okay, how much time it actually takes for the jugular vein to pop out, is that the term? Yeah, to be seen, right? Capillary refill time, PCV and TP, creatinine BUN, urine specific gravity, of course. Urine would get concentrated if it's the patient is dehydrated. The following are decreased in cases of dehydration. Skin turgor would be decreased. The temperature of extremities, urine output could be decreased to absent, or what we call anuria, and central venous pressure. Central venous pressure is you could put a catheter inside a vein, and it could actually measure the blood pressure inside that vein, which is cool. Because what you measure with the sphygmomanometer and the Doppler and the cuffs that you put in your patient is mean arterial pressure. Central venous pressure is different. So, I just wanted to point that out. Now, some literature have said that skin tint and mucous membrane dryness is not reliable in horses as it is in cows, so it is not recommended to be used. But one thing about PCV, TP, creatinine, BUN, and such, even if they are increased, right, it doesn't mean that it is just dehydrated. Okay, it's quite a very not really very. It's an unreliable parameter to base your decision on, because there's a lot that can affect these parameters, right? There's a lot of conditions that could affect your PCV and TP. What do you call this? There's a lot that could affect BUN and CREA, right? So again, when you choose your first bag of fluid, you lack these data, and while you're waiting for your lab results, while you're doing your blood collections and such, you just have to choose the best fluid in your mind that could replace any losses inside that body. Okay, so in equines, dehydration is not clinically apparent until it is at 3 to 5%, which is actually applicable to every animal species there is, right? 5% it's clinically seen, but by it reaches around 12-15%, your animal is dead. Alright? So one easy way to diagnose and treat dehydration in horses is by offering water. Remember I told you, kapag nauuhaw tayo, we feel dehydrated, we have this urge to drink. And when we drink, that actually treats it because we get what we need. So this is actually the most reliable guide to hydration status of horses. This is one article that I read. Na you could actually assess the hydration status by the volume of water consumed of the animal, which the normal is 5 to 10 gallons a day, and the frequency and duration of drinking bouts. Okay? So there's one quote that I read na you can lead a horse to water, but you cannot make it drink. Okay? And also, when it refuses to drink, it doesn't mean that it's not dehydrated. Because ang horses ay maarte. Alright? I've seen this multiple times when I was doing my clinical duty in a breeding horse farm in Santa Rosa, Laguna. It's near Nuvali. So, these are breeding horses, so medyo maarte sila, na when you replace the trough, the water is, they will not drink until you leave. Alright? So when you want to apply this this idea to the horses, you have to consider that there's a lot of reasons why they don't drink aside from being well hydrated. Right? Stress. You lack of time taken. Okay? Mabilis kang naghintay. Hindi ka masyadong matagal naghintay bago siya uminom. Okay? You have to give them at least 10 minutes alone to drink in a quiet environment with no competition. Alright? Because that's also one reason why they wouldn't drink. There's bullying. The water is dirty. The lalagyan ng tubig ay iba from what it was used to, which is very common when animals are moved from one place to another or from one pen to another. Right? Unsuitable new environment. Ayaw nila na maingay. Right? So these are, small behavioral things that you have to consider when you are making your judgment. And also, if the animal is unwilling to drink or unable to, even if lahat ng mga factors na to ay okay naman, you also have to ensure that there's no physical reason why it will not drink. There might be an oral foreign body, it might have a laceration in its tongue or problem with the teeth, right? It could have problems with choking. So you have to rule this out and then explore other options of fluid therapy, okay? If it doesn't work. If there's no way that this animal will be drinking, ayaw niya talagang uminom, okay? And you cannot fix the dehydration by, its willingness to drink, then you have to explore other options of fluid therapy. And of course, if this works, if it drinks, you have to monitor for urination. Urine output is the best indication of adequate fluid therapy. So you have to know the normal urine output of these horses as well. I think you will touch on that in med. I hope so. Okay? Let me know if you don't. because there's a lot of they call this, there's a lot of statistics on this, because there's a lot of researches. They said that the normal output for horses is 1.2 mil per kg per hour, and then I see one article which is just deviating by 0.5. They say it's 1.7 to 2 mil per kg per hour. So again, depends on where on what you read. It's usually an average of 15 liters per day. Yeah, average of 15 liters per day. Okay? So, ruminants. Now, sa ruminants naman, we were focused on finding what percent dehydration ang i-divide natin. With ruminants, you are more focused on the choice between the routes of administration rather than getting to the most accurate estimate of the fluid deficit, right? Because it's very, what do you call this? Variable. You have two main parameters that you check for calves. Okay? The eyeball recession, which is measured in millimeters. Gaano kalayo yung eyeball sa conjunctiva. And the skin tent duration is usually in the back of the side of the skin. The side of the neck, the back of the neck, and behind the elbow. Those are the usual sites for assessing for skin tent duration. But basically, the rule for this, there's a lot of other things, extremities, demeanor, and such. The rule that they apply for ruminants is guess and reassess. Okay, you guess a specific point in your percent dehydration. You give it what it needs based on your guess, and then you reassess, right? Which is actually what happens commonly in practice. We always guess and reassess anyway. Right? So, what factors which could make your exact estimation inaccurate? Emaciated cattle. So, emaciated cattle would have that pathological effect of eyeball recession and increased skin turgor. So, you don't rely on these kapag ang baka ay payat, right? What else? Body weight. Body weight can easily be affected by the amount of water or ingesta in the rumen. So, if it is, showing a heavy weight, it doesn't matter. It will still highly depend on how much the rumen is containing at that moment. Okay? So, cattle with other diseases or comorbidities, those with severe dehydration but normal GI function could resolve with only oral fluids. But those in shock or hypovolemia, you should go for IV fluids. So there's a lot of reasons why these physical parameters could show abnormalities na hindi naman pala dehydration. So, one thing with ruminants as well, they have this big ass stomach, okay, which makes enteral administration of fluids very advisable, very recommended for them. They tolerate it really well. Now, when do you give intravenous fluids? The standard, which is the same, it's just standard, the same for every reference that I've read, every book, is 8%. Once your patient, once a ruminant, sheep, goat, cow, calf, shows signs of 8% dehydration, you shift to intravenous fluids, right? And as you can see in that table for the guide for estimating dehydration, that is this one. Okay, eyeball recession of 4 millimeters, skin tent duration of more than or equal to 6 seconds. So let me show you eyeball recession. The upper, the picture on the top would be the normal one. Magkadikit yung conjunctive and the eyeball. And you see here, this calf, wherein there's this big distance between the conjunctiva or the lower eyelid and the eyeball. And if that distance measures 4 millimeters, that is actually a very severely dehydrated calf. institute intravenous fluid therapy. Skin tent, right? See that here, you could actually pinch these areas, you count the seconds until it goes back to its original position. All right, so that is how we estimate fluid deficit for our patients. This is a very long lecture. So again, guess and reassess is the name of the game for ruminants. And once you have identified the percent dehydration of your patient, if it is dehydrated, then you can now decide on what route of administration to employ for your patient. Let's start with enteral administration. Enteral administration is quick, cheap, easy to administer. It is also following the normal physiologic route of fluids because you are giving them those fluids through the mouth, right? And also, if you want to give oral fluids, they do not need to be sterile, not like fluids we give intravenously. And this is the primary method of managing mild to moderate fluid deficit. Which is less than 8%, and electrolyte deficits. In patients, again, they must have intact gastrointestinal motility. Okay, so enteral fluids are contraindicated in patients with ileus, intestinal obstruction, severe mucosal inflammation, in horses which are unable to stand. When you give enteral administration, ideally they are sitting up or standing up. Okay, so this is very well tolerated by ruminants due to their rumen size. However, in foals is not commonly used, and IV is preferred for foals. Horses tolerate this as well. That is one exception wherein I said enteral fluids are contraindicated if there's intestinal obstruction. In cases of impaction colic with horses, you want enteral fluids because you want those fluids to go directly into the gastrointestinal system to hydrate anything that's blocking the colon or any part of the large intestine, which helps because if you give intravenous fluid, they generally bypass the gastrointestinal system, which doesn't help. So you want enteral fluids for those cases, right? So fluids and drugs can be administered using the following equipment. Let's start with the basic ones, the suckling bottles. You could easily give oral electrolyte solutions with this, the colostrum, of course, milk replacers and such. For those who do not have the suckling ability, okay, you could give those fluids through esophageal feeders, the nasogastric tube, orogastric tube, and the bilge pump are also options for your bigger animals, right? So what are the advantages of enteral fluids? Again, they're lower cost. The gastrointestinal mucosa acts as a natural selective barrier for anything that you're giving. So if you're giving it yung nasobrahan ka ng konti sa bicarb na binigay mo, the stomach itself of the animal is gonna solve that problem. Absorption is increased with patients in hypovolemia, and how the enteral fluid goes into the vascular space is actually rapid. It's around 30 minutes. But then again, if you need your fluids to work instantaneously, then you need to give it IV. Okay? The 30 minutes waiting time is if you can wait 30 minutes, but if you are resuscitating a patient, you go for IV. Huwag mong ipilit na maglagay ka ng hose dyan sa bibig niya when you know it needs IV fluids. Alright. What else? This is good again in application to horses because hydration through enteral feeding stimulates intestinal motility through what we call the gastrocolic reflex. I'll make this easy if you don't remember the gastrocolic reflex. When you eat and then you feel like you're about to shit, that's gastrocolic reflex. Your body is trying to make space for whatever you ate. And that is detected by the receptors. Number one, chemoreceptors in your stomach, and also those receptors that are detecting the size of your stomach. It actually sends a reflex to your colon to move or to increase peristaltic activity so that you could evacuate and make space. Okay? And that works for horses, especially with colic. So what else do I need to say with this one? Yeah, I guess. Okay, let's move. Suckling bottles, as you can see, the one on the left is used for cows. The one in the middle is for sheep, lamb and kid. The one on the right is like the normal suckling bottle for horses, right? So this is basically for hand feeding sucklings. Okay, those with a good suckling reflex, you could give milk replacers, electrolyte solutions, and drugs. If you look at the middle bottle on top, you'd see that the teat has a pointed shape. That's what we call a Pritchard teat, and it's shaped like the U's teat. So it's good for those lambs and kids because it simulates how it happens. If your patient does not have any any suckling reflex, you could now go for esophageal feeders. However, the one article pointed out that the difference between suckling bottles and esophageal feeders is that when you give fluids or whatever to patients through esophageal feeder, the fluid ends up in their rumen, while suckling reflexes the suckling bottles would lead the fluids that you're giving to the animal straight to the abomasum. Remember, there's an esophageal groove that prevents fluids goes into the rumen because it's not yet developed. Majority of the stomach of a young ruminant is the abomasum. So that's one thing they said, but it still works. It doesn't cause any drastic bad effect. Okay, I said that. Oh, if you can see the probe or yung end nung feeder is could be blunt or enlarged or rounded so that it will not cause injury in the throat upon insertion, and it helps in bypassing the epiglottis, right? Because it's big. Patient needs to be standing. I said this. At least sitting up to prevent aspiration pneumonia, right? Leave this as a video of how it is done.
Hello, and welcome to this session of calf management tips, brought to you by Milk Specialties Global. I'm Elizabeth, calf specialist for the team, and today we'd like to cover how to properly place an esophageal tube feeder. Appropriate times to use an esophageal feeder would be in the delivery of colostrum, or when a calf is dehydrated and oral rehydration is appropriate. I'd like to start by showing how far to insert the tube. Typically, if you take the tube and place it to the shoulder of the calf and mark where the tip of the nose is, I like to put a piece of tape there, and I know how far to insert. It's important to immobilize the calf, and this can be done simply by backing them into the corner and stabilizing their head with your thighs. You then gently insert the tube over the tongue to the back of the throat and slowly apply pressure until the calf begins to swallow. The calf will fight slightly as he swallows it. You know you're in the proper placement when you can palpate clearly the windpipe and your tube. You then uncrimp the fluids and allow them to flow. Typically, when rehydrating, we like to deliver an appropriate amount of 2 to 4 quarts. Hello, and welcome to this session of calf management tips, brought to you by Milk Specialties Global. I'm Elizabeth, calf specialist for the team, and today we'd like to cover how to properly place an esophageal tube feeder. Appropriate times to use an esophageal feeder would be in the delivery of colostrum, or when a calf is dehydrated and oral rehydration is appropriate. I'd like to start by showing how far to insert the tube. Typically, if you take the tube and place it to the shoulder of the calf and mark where the tip of the nose is, I like to put a piece of tape there, and I know how far to insert. It's important to immobilize the calf, and this can be done simply by backing them into the corner and stabilizing their head with your thighs. You then gently insert the tube over the tongue to the back of the throat and slowly apply pressure until the calf begins to swallow. The calf will fight slightly as he swallows it. You know you're in the proper placement when you can palpate clearly the windpipe and your tube. You then uncrimp the fluids and allow them to flow. Typically, when rehydrating, we like to deliver an appropriate amount of 2 to 4 quarts.
All right, I'm gonna stop there. You see that purple clip on the tube near the bag? That's to occlude the tube so that kapag pinapasok mo pa lang yung feeder to the calf, you wouldn't be leaking the fluids inside the oral cavity, which could cause aspiration pneumonia. And when you remove it, you could when you're about to remove the feeder, when you're done, you could either move the bag down, para walang mahulog or mag-leak from the feeder, or you could clamp that button. Okay, I'm gonna show you the link. I'm gonna share you the link for these videos so that you could watch it at your own time. Right. Now, nasogastric intubation. This is when you pass a tube through the nostrils of the animal to the stomach. Indications, especially for horses, would be for impaction colic, which directly hydrates the intestinal contents, stomach emptying in cases of gastric overfilling. You want to remove some of those things. Drug administration, of course, and enteral nutrition for those patients who are unwilling to eat but tolerant to the procedure. Now, it's not a perfect thing. There are contraindications for it. Hemorrhage. Okay, sorry, not contraindications. I'll just say the contraindications. The contraindications for this would be ileus, severe dehydration or hypovolemia, which requires intravenous therapy, impaired absorption in the gastrointestinal tract, and again, those conditions needing rapid resuscitation. So complications, since you are passing a tube through its nose, wherein the nasal turbinates are very much well developed. You have to prevent injury to that, and when it happens, it causes hemorrhage, and hemorrhage in the nose, in nosebleed from a horse is really bad. You think it's like a major injury. You'll also cause friction to nasal mucosa when you don't do this properly. What you could do is actually lubricate the end of the tube when you insert it, so that you will not cause any injury in the nasal mucosa. Aspiration pneumonia when you put it in the wrong place, and gastric rupture when you put it too much, too deeply. All right. Okay, there it is. I'll skip that. I'm supposed to show you a video in the next slide, but I'm gonna skip it because I'm already running 1 hour and 30 minutes.
Stool.
Alright, so the one on the right side is a bilge pump. This is actually just used to place fluids into the tube much faster.
The contents.
So enteral fluid flow rates in horses, how much do you actually put in there? Okay, so the movement of fluids through the proximal gastrointestinal system of a horse is pretty much standard. It's rapid, which enables large volumes of fluids to be administered to horses. So the rate depends on the degree of dehydration and primary condition to be treated, if any. And the total daily fluid requirement may be divided into 4 to 6 boluses per day, with a maximum of 6 to 8 liters per administration over 10 to 15 minutes. Right? That's a bolus. Okay, that is a bolus. Meaning you're just giving it for over 10 to 15 minutes, then remove the tubing, and then you come back later. Okay? The maintenance rate for a horse, again, it's 2.5 ml per kg per hour. So when I give you a problem with all these things, how do we go about it? Right? 400 kilo Arabian male horse has an estimated 5% dehydration. Calculate for maintenance, replacement, and enteral fluid plan. Alright, this is how we're gonna do this. I am not sure if I could give you practice problems for this, but I guess it's easily followed when you do this, right? One thing pala, if you're wondering, the stomach capacity of a horse, adult horse, is around 2 to 4 gallons. When you convert that into liters, it's around 16 gallons. Right? That's the stomach capacity of an adult horse. So you don't have to worry if you're giving 8 liters over 15 minutes. Perfectly fine. Okay? So how are we going to go about this? Right. So we have a body weight of the horse. We have the percent dehydration. We have to first compute for number 1, maintenance. Okay? Yung L dyan na naka-parenthesis, that's the unit for your answer. Okay? So you need to give me the liters. So for maintenance, we're going to multiply the body weight with the what? Maintenance rate, which is 2.5 ml per kg per hour. But we're talking about per day. Per day. That is 24 liters. Fluid deficit, which is number 2. That's the replacement. Okay? Again, I didn't say if there's ongoing losses. Don't complicate things. Just fluid deficit. 400 kilo times 0.05. That is 20 liters. Correct? So, if we are going to divide the boluses, if we are going to administer the fluids enterally through a nasogastric tube through boluses, meaning we're just gonna give it every for 10 to 15 minutes every time. Okay, let's decide on the divided boluses. Let's say 44 liters, which is the combination of maintenance and the replacement. We want to give this amount, we want to give this every 6 times a day. Okay, 6 times a day, which is every 4 hours. Okay, so 44 divided by 6 is, calculators out, that is 7.3 liters every 4 hours. Alright, that's how much we are gonna give it. Okay? So, now, kung ayaw ko nang magpabalik-balik, okay, I just want to keep it there, like this, okay, like this patient, okay? What is the, call this the computation for that? You have 44 liters, right? You divide it by, how many, 44 liters is the amount that you need to give for what? For a day, right? So you just divide it by 24 hours. So that is 1.8 liters per hour. That is your flow rate. Remember before, when we are in small animal surgery, we're discussing one drop per 10 seconds. Okay, it doesn't work here because we're talking about large animals. We're talking about liters per hour unit of measurement. Okay, now how do you actually find out if you're giving 1.8 liters per hour? For some some farms which are posh enough to provide intravenous fluids to their patients, or even enteral fluid therapy for their patients, they could connect that fluid sa pump, and they could place it, and they could indicate sa machine how much it should give to the animal every hour, or you could actually just observe it. Yep, easy. You just observe it. So, I'm not gonna go into that, how many drops. You could compute for it, sure. I'm gonna show you later the drops per mil. It's actually 10 drops per mil. you could do that, but I'm not gonna go into that. Alright, so aside from fluids, what could you give orally? Oral electrolytes, which is very much important for calf scars. Okay, so you can mix it with water. You give it through the nursing bottles or through an esophageal feeder, and this is primarily to treat and manage neonatal diarrhea, which happens very often in foals and calves, and hindi siya bacterial or viral in nature commonly. Okay? It could, yes. It could be caused by bacteria or viruses, but commonly in young foals and calves, it is actually caused by husbandry, number one. Number two, the lack of colostrum, or they were not able to suckle enough, or they weren't able to suckle any colostrum in time, which caused their immune system to actually go down. So that's one basic reason for that. So this is also one thing that you give orally, and it's also a part of fluid therapy. These are the contents for that. I'm gonna leave you to read this, okay? Because it's more of med. I just decided to put it there for your own perusal. Right, sub-Q. Yes, it is done again for mild to moderate dehydration. Now, it is not commonly done in horses and foals because they have low tolerance for it. Yes, you may see it done, but enteral is preferred for horses, especially for mild moderate dehydration. Much easily done, and it's, I don't know, I think it's much of a preference for it. And again, sub-Q, you can only use 0.9% saline solution. You cannot give anything else. Right? Where do you place it? Loose skin area of the neck, shoulder, behind the elbow. Basically, where you check for skin tent. Okay? Now, I've read one thing that there's a limit, 500 ml in one location. Then again, if you need to give it a lot.
Stabilize the calf to the best of your ability. I like to do this by backing them in a corner and securing their head and neck with my thighs. You can uncap your needle, make a tent with the skin, and place the needle gently into the skin, being careful not to administer it into the muscle. You know you're not in the muscle if you're still able to freely move the needle and it's not held taut. You may then uncrimp the fluids, elevate the bag and allow them to flow into the calf.
You could actually combine, what call this? I'm talking. You could actually combine subcutaneous administration with other routes of administration. It depends on you. Okay? Yep. You just pinch, you insert the needle, and you hang the fluid up top and let it move down. Now, intravenous administration, basic, right? This is the choice for fluid therapy administration for those with severe dehydration, which is greater than 8% for cattle, and hypovolemia, which requires immediate correction and circulatory support. Now, it is not just for restoration of the blood volume, but this is also the opportunity for you to correct any acid-base abnormalities and electrolyte deficiencies. So, yung mga pasyente na hindi rin pwede for enteral fluid therapy, this is what you use for them. So, those with ileus, inefficient GI motility, those with gastric reflux, meaning when you put the nasogastric tube inside, and then you were able to drain easily without anything. Around more than 4 ml per kilo of fluid, stomach fluid out. This is gastric reflux. Then you cannot proceed for enteral fluid therapy. You have to explore intravenous for that. For those with enteritis, okay? So this requires strict aseptic technique, especially when placed in horses because they are very much at risk for septic thromboembolism, which we will be discussing later. What are the materials for this? Just imagine everything bigger, right? The pink one here is your normal 20 gauge. What you use for horses, especially if you're going for a jugular stick, is a 12 gauge to 14 gauge IV catheter. 12 gauge is, I believe it's actually orange. Gray is 14. Let me check my notes. Never mind. Alright, so you could have different lengths for this. 2-inch for short-term IV, which is just 3 days. 5.5-inch for long-term, which is greater than 3 days. However, commonly the way that we do this is that you replace catheters every 3 days. So again, depends. One thing that you have to focus on with horses, dahil mas market sila, practitioners are concerned with the quality or the nature of the catheter. If it's made from polyurethane, that's the least thrombogenic, which is good. Teflon would be the most thrombogenic, so you steer away from that. Commonly in horses, you do not just put an IV catheter and then ikakabit mo agad yung IV line. You usually connect an extension line, which enables you to lock in different kinds of fluids in one line, or you could give drugs in one port and then you have IV connected to one line. So this is good. We actually use this for dogs and cats as well in critical care, wherein yung isang line na kakabit ay maintenance fluid, yung isa ay blood, or yung isa ay may inotrope or vasopressor in it. So again, depends. How to secure IV catheters in large animals? You use suturing materials. Yes, you have to suture it to the skin, right? You use your non-absorbable suture with a cutting needle, or you could do that. Or if you do not have any needle holder, you could actually insert the suture inside a needle itself. There's a video later on how you could actually suture it there. In horses, infiltration of lidocaine on top of the jugular vein is actually advised because you're putting in a 12 gauge in there, which is harsh. Alright. This is heparin saline flushes para hindi mag-clot yung catheter. And how you secure them, some would use adhesives for that. All right. Ooh, I didn't animate this properly. So for equines, the site is the external jugular vein. So you have to find the jugular groove first. Okay. You occlude it on the middle where the yellow line is placed in the second picture. Okay. Because as you can see in the picture on the left, okay, kapag mas malapit sa thoracic inlet, yung call this, kung saan ka magsistick, the carotid artery is actually really near the jugular vein. So you want to do your sticks, okay? You do your catheterization and your venipunctures on an area of the jugular vein wherein it is far from the carotid. And that is more cranial than caudal. So you have to move farther like this, right? Because as you go cranially, the omohyoideus muscle becomes thicker and thicker, right? So the direction for IV injections, as seen in this red arrow, not red arrow, black arrow in the left picture, okay? That is what we call anterograde, meaning towards the heart, okay? With the blood flow, which comes from the head to the heart, because it's the vein. So that's anterograde. For normal blood collections, like what he is doing, you will insert the needle retrograde from caudal to cranial. Okay. Now, is there another option aside from external jugular vein? Yes, there is. This vein on the side of the animal, that is the superficial thoracic vein. Okay, quite wiggly. You may not be able to place, a 5-inch catheter there. So you have to be very careful with that. Pero kapag hindi lang pwede gamitin yung jugular, that's another option. For example, there's a problem on the neck that makes the jugular, we call this, na hindi pwedeng gamitin yung jugular because probably there's a wound there. Number 2, if there's coagulopathies in this horse, which might cause hematoma on that area, so there's another option. Okay. So how do you do this? You aseptically prepare the site of the IV catheterization. You actually prepare it like a surgical site or a surgical field. Okay. You occlude the area to visualize the external jugular vein. You infiltrate it with lidocaine subcutaneously, and then you repeat the sterile scrub. Now with your catheter, you occlude the jugular vein in that area until it bulges. Okay, very easily seen. You insert with conviction your IV catheter. You wait for the blood flash. Okay, and when you hit that, you remove a little bit of the stylet. You withdraw the metal, and then you advance the plastic inside. Right? So if there's no resistance, keep it there. If there's resistance, you attempt to reposition. Okay? And then you withdraw the needle, and then you cap the catheter to prevent any contamination. Okay, fast video about this. No, maybe not fast. Okay, skip through it. Shave. Shave. Lidocaine. Alright. So when you inject lidocaine, you actually fan out. See how long that is? Yep. That's why you need lidocaine. Because imagine that. Your horse might kick someone because of that. And as you can see, the person is wearing sterile gloves. Okay, you have a dirty hand and a clean hand. The dirty hand will occlude. Clean hand will be inserting the catheter. You wait for a blood flash. Whew. You check, there it is. You cap it, you advance. There you go. Okay, you get the cap. You gently cap it. That's the connector. It's a T connector. Okay, you flush it. Ooh, you're in. Right? And how do you secure it? You suture it in. Okay, let's go back. Alright, she inserted the suture inside a needle. Alright, she inserts that needle to the skin where she put the lidocaine. I don't know if it's a he or she, I'm sorry. Didn't ask for her pronouns. Okay, so the suture is now inside the skin, and that's what you use to secure the IV inside. There's the IV on top of the skin. Ugh. My sleepiness is getting to me. Right? That's it. Then you can actually repeat that over and over again to other parts of the horse to fully secure your IV catheter. Okay? Now, question. Are they gonna cover that? Imagine, the cephalic vein of a dog is easily covered. Do they cover that? Not really. It's not advisable to cover it if they're gonna be there for just a while. The horse cannot contaminate it. They cannot reach it. And also, they would rather see the junction of the skin and the catheter to make sure there's no complications happening, because it's very common in horses. Right, next. To the subcutaneous space through gravity alone. Right? That's it. So in ruminants, basically again jugular vein. Another option would be the auricular vein. Same way of IV catheterization as horses, except in cows, because their skin is quite thicker than horses, you might need to do venous cut down, wherein you make a small incision on top of the jugular vein, and that makes the insertion of the catheter directly to the jugular vein much easier. So if you place IV catheters to ear vein, you secure it with a wraparound bandage, or you could also suture it. Now, I think I've shown you this before, the IV coil set. Okay, imagine your IV line, but it's coiled. All right, a big part of it is coiled. It actually enables the animal to move a lot during IV administration. They could lie down, they could eat without restraint, so which is really good. It prevents multiple lines from being tangled and being stepped on. So you could see that hanger that I included in the picture, right? That's called as IV fluid hanger, which it could turn the fluids 360 degrees as the animal moves para hindi nagtitwist yung IV line. And it is commercially available at 10 drops per mil or 60 drops per mil, and it is actually used in cats as well, diba? For minimal supervision. It's really good. So, what else? Yeah. So that's it. Complications, I think you could estimate this one. Fluid overload, when you give too much, right? You could see signs of this as leukemia, pulmonary edema, which is visibly seen in nostrils and large airways, visible subcutaneous edema seen on the left side. A picture, polyuria and dilute urine. If you see urine that is less than 1.020 in specific gravity, you might have to rethink your fluid therapy. Another complication regarding the vein, which is very common in horse, would be phlebitis, just inflammation of the vein. Thrombophlebitis, you combine that with a formation of blood clot, and septic thrombophlebitis, you add an inflamed occluded vein with infection with bacteria, then that's the bad thing. So the common isolate or the common causative agent for this is a Pasteurella species. So they could easily spread to the bloodstream, cause systemic infection, which leads to sepsis and septic shock. Then you're back to a patient which needs resuscitation. So what are the causes, of septic thrombophlebitis? I'm just going to enumerate these, and they are, commonsensical. Right? So, all right. So in your fluid therapy, you could actually include or infuse your analgesics in the IV bag, so that there is a continuous infusion of a drug to the body of the animal. Right? So again, analgesics, intermittent or continuous. Yung intermittent, ito yung every 4 hours, every 6 hours. But if you could maintain the level of drug inside the animal's body, that could do a big difference pagdating sa pain management ng hayop na yan. Alright? So, I'm sorry with the animations. Right? So, how do we actually do this? So, the steps for continuous rate infusion, which is also applied for small animals anyway. I just did not add this during surgery 1 and surgery 2 because it's not that they're quite complicated. It's just that that is an introduction to you for fluid therapy. Kapag pinurga ko kayo nun, baka wala na mag-stick. So I just included this here. And it's also commonly done in large animals. Alright, the first step is that you calculate your flow rate for the animal, okay, with the normal fluids. Okay, you divide the size of the fluid bag by the number of liters per hour that you computed in number 1 to get the number of hours it will take to empty the bag. Okay, we'll have an example on the right side later. So, with the pain medication, you calculate the amount of pain medication you need per hour. then you multiply them together. So, example, mas madali to sa example. I'll give you these data. A horse, 500 kilogram body weight. The maintenance fluid rate that is this computed for this is 1 liter per hour. Okay, I already gave you that. You don't have to multiply. That's the maintenance fluid rate for this horse, right? Then your IV bag is actually 5 liters. Diba ang common sa atin, like I said, is only 1 liter. Let's apply what is used commonly in the different countries, which is 5 liters. There's also a 10-liter bag, but let's go with 5 first, right? And the drug, the pain medication, detomidin, which is used in horses, very good pain management. I think it is a alpha 2 agonist. Yeah. So the rate for that is 0.01 mg per kg per hour. Okay? The preparation for that is 10 mg per mil. I already gave you this. Okay. I did not compute anything yet. I just gave you all that. Right. Number 1. How much detomidin does this horse need? Okay? So how much of detomidin does this horse need? The only data you need there is the body weight of the horse and the dose for detomidin. 500 times 0.05. Sorry, 0.01. 500 times 0.01. That gives you 5 mgs per hour. Right? Yan yung amount ng gamot na kailangan ng hayop na to per hour. Alright? So, if we are going to infuse that into the bag, which is a 5-liter IV bag, right? How much in milliliters do we need to give? Okay? First, we have to convert the 5 milligrams into ml. Okay? We apply that with a preparation, 5 mg per hour divided by 10 mg per ml. That is 0.5 milliliters per hour. Okay? Now, where is that? The number 2 step, the second step, actually. The 1 5-liter bag that you have will last for 5 hours. How do I know that? Your maintenance fluid rate, look up, is 1 liter per hour. Meaning 1 liter of that fluid will go into your patient. Okay? So a 5-liter bag will take 5 hours to be emptied. Okay? So, if you need your horse to receive 0.5 ml per hour detomidin, how much of the detomidin will you have to put inside the bag? It's very hard to teach this in this setting. So much easier if we're actually face to face. So all you need to do is multiply the amount of drug that you need to give per hour and the number of hours that bag will be emptied, which is 5 hours. So that is 2.5 ml detomidin. Easy as that, right? Yeah, easy as that. Alright, so you just need different examples for this. Alright, so I know you'll do fine with this. Oh shit, I have like 3 minutes until this is 2 hours. Oh no. Alright, so these are different analgesics commonly used in clinical setting. These are their doses, and this is the CRI, the continuous rate infusion doses as well. Use this as your reference. Lastly, glucose supplementation. You could also include glucose in your IV fluids, especially for those weak foals and calves. However, this is not an alternative for proper colostrum feeding and for enteral feeding if you can. That is still the best way. But if you need immediate correction of hypoglycemia, you could use this. The rate for glucose is 1 to 4 mg per kg per minute IV CRI. Alright, when I say CRI, it's continuous rate infusion. Alright, and remember, it's not per hour, it's per minute. Okay, so you have a 50 kilogram anorexic foal. The rate that we will use here is 4 mg per kg per minute. I want you to calculate for the infusion rate for this foal using 10% dextrose. How do we go about it? Of course, you have to identify first gaano karaming glucose ang kailangan niya per minute, right? So, you multiply 50 kilograms with a rate, and that is 50 times 4. 200 milligrams per minute, right? That's per minute. Let's make it easier for us. We always talk into per hour, diba? So 200 milligram per minute times 60 minutes, because there's 60 minutes in 1 hour. FYI. Right? That is 12,000 milligrams per hour. And how do we actually compute for the infusion rate? Diba? Now we're going to make the milligrams into ml. Remember, I gave you one key. You're going to use 10% dextrose. 10% dextrose means, if written differently, that is 100 milligrams per ml. Okay? When you say 10% dextrose is 100 milligrams per ml. 5% dextrose is 50 milligrams per ml. Alright? So, with that in mind, you get your 12,000 milligrams per hour, convert that into ml per hour, you get 12,000 divided by 100, 120 ml per hour. So your foal is infused with 10% dextrose at a rate of 120 ml per hour. Alright? So that is a rough lecture on fluid therapy. I apologize for not being able to meet you through Zoom. It's a combination of me not being here at home, and 2, I feel that the PowerPoint that I made is still not enough. Even right now, I think it's still not enough. So next week, we're going to be discussing anesthesia in large animals instead of a practice fluid therapy problem. For this subject, I will give you a full exercise in fluid therapy computation, which I will be again uploading on Monday 12 noon, but you are not required to submit that in 6 hours. Again, the ultimate deadline for that is on the end of the semester with the other requirements. Thank you all for bearing with me for 2 hours. If you have any questions, I expect questions for this. Don't forget to message me, and if you can, please do not make your, if you want to, don't make your questions private so that other students can actually read your comments. All right, so you could comment, you could put it instead in the class comment instead of your individual comment. All right. Anyway, thank you once again. I will try to see you next week. Thank you all. Have a good week.